Hello guys, so before starting the video I just wanted to let you guys know that from where do I get my study materials for my YouTube videos prepared. Actually a lot of students have asked me in person also that from where do I get my study materials from. So to answer that, I prepared these lectures from USMLE books, USMLE step 1 and step 2 CK, and Pathoma, which is a short book of pathology written by Dr. Abdustar. So I consult these books to prepare my lectures, not only to prepare my lectures but for myself. I use these books to study. So I do not have much videos uploaded on my YouTube channel yet, but whatever I have uploaded, I have consulted these books. Enjoy the video. Alright guys, so today we are going to discuss the part 2 of acute respiratory failure. The part 1 we have already discussed and the video is already uploaded on the YouTube channel. So today we are going to discuss the part 2, which is acute respiratory distress syndrome. As we studied previously that under the umbrella of acute respiratory failure in your USMLE step 2 CK first aid book, you will see two topics, hypoxemia and ARDS. So today we are going to cover ARDS, acute respiratory distress syndrome. So before going into the details of acute respiratory distress syndrome, let me just define what does it mean by acute respiratory distress syndrome. So it is simply the diffuse damage to the alveolar capillary interface. Diffuse damage to the alveolar capillary interface. So first of all, you have to know what does it mean by the alveolar capillary interface. So the diagram is just in front of you. You can see that this is the alveolus, right? One single alveolus, and this is the blood capillary. Now, as you can see that our blood vessels are lined by specialized epithelial cells called endothelial cells. All right. And the alveoli, our alveolus, that is lined by these specialized type of epithelial cells. These are called pneumocytes. Now there are two types of pneumocytes, type 1 pneumocytes and type 2 pneumocytes, based on their function. And we all know that type 2 pneumocytes are responsible for the production of surfactants. And you all know that how much surfactants are important to our body, to our lungs, especially when as far as the lungs maturity is concerned. From the pediatrics and from the gynecology, if you remember that if during the child is born premature, right, we make sure that its surfactants are properly developed. If the surfactants are not properly developed, then we can somehow delay the birth. Right. So even if in emergency cases where we have to do the emergency delivery of the baby, we have to see that whether the surfactants are developed or not, because they are very, very important. Without surfactants, the child lungs will all collapse. The child will not be able to survive. So type 2 pneumocytes are those cells which produce surfactants. Now, coming back to the alveolar capillary interface, what is alveolar capillary interface? So you see these cells, these epithelial cells and these endothelial cells, and the interstitial spaces and this space which between the alveolus and the capillary, all of these comprise alveolar capillary interface. Right, so that's what we call alveolar capillary interface. So these cells, epithelial cells, endothelial cells, and the spaces between the alveolus and the capillary, that's called alveolar capillary interface. Now diffuse damage to the alveolar capillary interface. What inflicts this damage? What causes this damage? There can be many different causes of the damage. For example, it can be secondary to some disease process, for example pneumonia, right? You all know that pneumonia can cause damage to alveoli, especially type 1, type 2 pneumocytes. And the cytokines which are produced in pneumonia can also inflict the damage on the endothelial cells of the capillaries, right? You can also see this damage in case of sepsis, right? So sepsis is a widespread infection in the body, and when that infection spreads to our lungs, that can cause and inflict the damage to this alveolar capillary interface. Apart from that, pancreatitis can also produce damage to the alveolar capillary interface. Now you might be wondering why pancreatitis. It's a different story altogether. How pancreatitis is involved in producing the damage to the alveolar capillary interface. So there are two mechanisms through which pancreatitis can inflict the damage to the alveolar capillary interface. The first mechanism is that in severe pancreatitis, the inflammatory cytokines which are produced, right, inflammatory cytokines that are produced, those cytokines can become the part of our blood circulation, right? When they get into the blood circulation and when they reach the pulmonary circulation, it is most likely that they are going to cause the inflammatory response over there also. When inflammatory response there is activated in our pulmonary circulation, that can lead to the damage of the alveolar capillary interface. So inflammatory cytokines which are produced after the acute pancreatitis, that can also lead to alveolar capillary interface. The second mechanism through which acute pancreatitis can lead to damage of acute alveolar capillary interface is through direct hypercoagulability, right? So we all know that pancreatitis is a condition which leads to hypercoagulability within the blood. It causes the blood clots to form more eagerly. How can we say? We can say that blood clots are more likely to form when there is acute pancreatitis. So that is hypercoagulability, right? So blood's hypercoagulability increases in case of acute pancreatitis. That hypercoagulability leads to the formation of deep venous thrombosis, right? Because the clot formation becomes very easy, it will become very easy for the deep venous thrombosis to develop. And if this becomes embolized, if DVT becomes embolized, it is quite possible that that embolus may go and stuck into the pulmonary circulation and cause pulmonary embolism. And pulmonary embolism is itself a condition which will compromise the blood supply to the pulmonary circulation. If the blood supply to the pulmonary circulation is compromised, that will cause and inflict ischemia related injury to the alveolar capillary interface. So this is how pancreatitis can cause damage to the alveolar capillary interface through these two mechanisms. Second one is fourth one is DIC. The DIC is diffuse intravascular coagulopathy or disseminated intravascular coagulopathy, right? What is disseminated intravascular coagulopathy? This is also a condition, a pathology of coagulability in which the person develops the tendency to form multiple clots in all of the circulation. So if that increases the coagulability of the blood, and if the clots are start to develop in the pulmonary circulation, you can imagine what will happen. That may even directly lead to ischemia through pulmonary embolism, right? So that's what DIC and pancreatitis do to our lungs. Okay, they increase the coagulability, and increased coagulability can directly damage the alveolar capillary interface. You know how already, right? So that's one thing. And infections, any sort of infections, right? Drowning and trauma. So these are the other conditions that can damage the alveolar capillary interface. So now you know what causes the damage to alveolar capillary interface. All right, but what actually happens? What exactly happens when the alveolar capillary interface is damaged? All right, so first of all, you have to know that because alveolar capillary interface is damaged, there is an inflammatory process going on. Whenever there is inflammatory process going on, there is increased permeability of the blood, right? The blood vessels become more permeable, right? Okay, so if this is the blood vessel, let me draw the blood vessel for you. If this is the blood vessel and these are the endothelial cells, okay, after the damage, these endothelial cells in the blood vessel will become like this, okay, like this. There will be increased spaces between these endothelial cells. So we say that the permeability has been increased, and this permeability is achieved through different mechanisms, right? So you all know from your basic pathology, from your inflammation chapter, that how permeability increases after the damage, or after cytokines related damage, or after direct injury mediated damage, how this permeability increases. Now, because permeability is increased, what will happen is that the protein rich fluid will start leaking out into the alveolus. From the blood, the protein rich fluids will start leaking out into the alveoli. Because protein rich fluid is already leaking into the alveoli, the fluid will start to accumulate here, right? Not only that, you all know that here the inflammatory process is going on, right? Wherever there is inflammation, there is release of cytokines, right? And those cytokines attract neutrophils. Attract what? Neutrophils. And neutrophils get activated. When neutrophils get activated, the activated neutrophils release proteases. What they release? Proteases. Proteases are protein digesting enzymes simply. So when proteases are released, right, these proteases start damaging type 1 and type 2 pneumocytes of the alveoli. These type 1 and type 2 pneumocytes, right? So when type 2 and type 1 and type 2 pneumocytes are damaged, their necrotic debris that sits down within the alveolus, right? So now within the alveolus you have got two things. Number one, protein rich fluid which is coming out of these blood vessels, number one. Number two, the damage to the type 1 and type 2 pneumocytes causes the necrotic debris to form, and that necrotic debris will settle down. Now that protein rich fluid plus this necrotic debris, that will combine to form a membrane called hyaline membrane or hyaline membrane, right? That is very, very important in pathophysiology of ARDS. Now this hyaline membrane consists of protein rich fluid, right, and the necrotic debris plus fibrin, right? So it is kind of a membrane which develops and starts to form the inner lining of the alveoli. This membrane now starts to form the inner lining of the alveoli. So the inner lining of the alveolus, which was normally formed by type 1 type 2 pneumocytes, that is now replaced by hyaline membrane. Now this hyaline membrane makes it very difficult for the gaseous exchange to happen, because this is consists of necrotic debris and protein rich fluid, right? So it makes it very difficult for the normal gaseous exchange to happen. That is when the patient conditions start to worse, and we say that the patient is going into acute respiratory distress syndrome, right? So if we define acute respiratory distress syndrome, we say that when the person cannot maintain his ventilation. Suppose when I take a breathe in, right, normally I will exhale out with ease, all right, with ease, but these patients, they have very hard time breathing in. Why they have hard time breathing in? Because their alveolar capillary interface is damaged, right? Their type 2 pneumocytes are damaged, the surfactants are not there anymore, right? And that will increase the surface tension within the lungs, right? So let me explain what actually happens. So this is the alveolus, all right. So whenever there is hyaline membrane formation, here is hyaline membrane, right? And type 2 pneumocytes are already damaged, you all know that, right? So that hyaline membrane will increase the surface tension, okay. What does it mean by increased surface tension? So we all know that plasma rich fluid, when leaked out into the alveoli, that plasma rich fluid is of course of liquid, right? So the liquid molecules which are present in the alveolus, because of the protein rich fluid that had leaked out, they develop cohesive forces between them. When they develop these cohesive forces between them, right, the liquid molecules become cohesive, right, and they do not go out of the alveoli. They become permanently settled in the alveoli. When they become permanently settled in the alveoli, do you think there will be any space left for the air in the alveoli? Of course there will be no space left for the air in the alveoli. If there is no space for the air, right, we all know that alveoli are designed in such a way that at all the times normally some amount of air is left behind in the alveoli. Even after we expire the air, even after exhalation, some amount of air is left behind in the alveoli. Why? That is a mechanism through which we breathe, because if all the air goes out of the alveoli during the exhalation process, then it will become so difficult for the alveoli to become open again when we inspire. So let's just simply say that it will become difficult for us to reopen our alveoli if the entire air which was present in the alveoli goes out, right? So that is why nature has provided us this mechanism, that at all the times some air is already present, always present in the alveoli. But imagine if that space is occupied by the liquid molecules, the protein rich fluid and the hyaline membrane, do you think any air will be left behind in the alveoli? No, there will be no space for the air to be left behind even after exhalation, right? So after exhalation all of the air will go out, no air will left behind. So what will happen, that during inhalation process we will have a hard time to reopen our airways. reopen our airways, because no air is already there, no pressure is already there. So we are maintaining an extra amount of effort to reopen our airways. That is one difficulty that the patient of ARDS experience, right? That condition is called distress condition. What is called? Distress, right? So now I think you all understand the definition of distress, right? That it is simply the difficulty to inhale. Why difficulty? Because there is no pressure in the alveoli, there is no air in the alveoli are already collapsed, and it will become so hard for us to reopen them again. That is simply called distress, right? So that is how the acute respiratory distress syndrome develops, and that was its pathophysiology. Now that's one thing that I wanted to discuss before going on into the clinical section, that ARDS patient with mild damage to the alveolar capillary interface, they may resolve on their own, right? We all know that whenever there is mild damage, the body has the capacity to regenerate itself. So by the reepithelialization of type 1 and type 2 pneumocytes, these patients with mild damage, they may resolve on their own. But if there is severe damage to the alveolar capillary interface, and that damage has been there for long periods of time, then they heal by fibrosis. So that's one thing that you have to remember, that ARDS is a condition which develops rapidly, right? But even if there's mild damage, and that starts to happen again and again and again over time, that becomes chronic, and these people, they heal by fibrosis, and there is nothing that we can do about it. We have to just manage the symptoms and maintain the quality of their life. So now we are done with the pathology and pathophysiology section of acute respiratory distress syndrome. Now let's just come to the clinical section of acute respiratory distress syndrome. So first of all, the patient comes, and first of all we have to take history, and we have to perform the physical examination. So what will we find on physical examination? We will find that this discomfort that the patient is feeling, that has acute onset, means that is new. Okay, that's new, that's something new which has recently occurred within the window of 12 to 48 hours, right? So distress is new within the 12 to 48 hours that has just started. And secondly, we will find that the patient is tachypneic, right? You all know tachypnea means rapid breathing, and dyspnea is shortness of breath. The patient will be cyanotic, of course, because of hypoxemia, right? There is no proper ventilation cannot be maintained, that leads to hypoxemia, and hypoxemia ultimately leads to cyanosis. So that's what on physical examination we will find. Now, what are the phases of acute respiratory distress syndrome? Basically, acute respiratory distress syndrome ultimately leads to failure, we all know that, but it doesn't lead to failure all of a sudden, right? It passes through phases, it has phases, and then it leads to acute respiratory failure. So what are those phases? As you see, in phase 1, the physical examination findings will be normal. So that's very, very interesting. The physical examination findings will be normal. There might only be dyspnea and tachypnea, right? And that dyspnea and tachypnea may lead to respiratory alkalosis. You all know that whenever we breathe too fast, right, and we are doing an attempt to get rid of carbon dioxide that is getting accumulated in our blood, right? That's why we breathe too fast. So in dyspnea, when we breathe too fast, or tachypnea, right, we are getting rid of extra carbon dioxide. When we get rid of extra carbon dioxide, we know that carbon dioxide in our blood, when it combines with H2O, it forms carbonic acid. Okay, it forms carbonic acid. But when we are getting rid of extra carbon dioxide, it means there is no formation of the carbonic acid, right? And that will lead to alkalosis, because the acid is not getting formed. That will lead to alkalosis. Because this alkalosis is because of respiratory reasons, we call it respiratory alkalosis, right? So the pH of the blood will go up, right, because of alkalosis, and the cause is respiratory, so we call it respiratory alkalosis. That happens in phase 1, when the body is compensating, when we can get rid of extra carbon dioxide. That's when we are in a compensatory stage, right? That's phase 1. Now phase 2, that is also a kind of, you can say, compensatory stage, because still we can maintain that ventilation, we can get rid of extra carbon dioxide, we can maintain that respiratory effort, right? So it's not a failure yet, right? Because still compensation is there. So you see there will be hyperventilation, means we will be rapidly breathing, right, to get rid of carbon dioxide that is accumulating in our body. And that there will be hypocapnia, of course, because we are getting rid of carbon dioxide, so there will be hypocapnia. And you know that hypocapnia means low partial pressure of carbon dioxide within the blood, right? Because we are getting rid of carbon dioxide. And of course respiratory alkalosis will also be seen here, right? And you can also see one more thing, there will be widening of the AA gradient. You all know what is AA from the previous video. A is the partial pressure of oxygen within the alveoli, and small a is the partial pressure of oxygen within our capillary blood. So you will see the widening of the AA gradient. That's what you see in phase 1 and phase 2. These are compensatory phases. But phase 3 is not the compensatory phase, right? Acute respiratory failure will start to become visible or will start to become evident in phase 3, right? So you will see acute respiratory failure. You may still see tachypnea and dyspnea in these patients. You may see scattered rails. You may hear the scattered rails on auscultation. Why scattered rails? Because we all know that our alveoli, they are now filled with protein-rich fluid, right? And that even is cohesive in nature, right? So that may give rise to the scattered rails on auscultation when we perform the auscultation, right? So that may give rails on auscultation. And there will be diffused opacity on chest x-ray. Opacity simply means to become white out, right? When the area becomes white out on chest x-ray, we say opaced or opacity, right? So on chest x-ray you will see the diffuse opacity, means the entire lungs or entire lobe will be white out, will be white. Okay, so you will see diffuse opacity, and that is when the acute respiratory failure has been inflicted already, right? But even up to this phase we can still save the patient. We can still save the patient by maintaining the external ventilation. But once the patient goes into the phase 4, we cannot save the patient, because this is the severe hypoxemic state, right, which is unresponsive to therapy. Means even if we maintain external ventilation, right, that will not be of any help. The patient will not respond, right, because the compensatory state is already over. The patient is in a state of decompensation. We maintain external ventilation, the patient will not respond, right? And there will be respiratory and metabolic acidosis. Initially we saw alkalosis, but in the decompensatory state we see acidosis, because we are not getting rid of carbon dioxide now. The patient is not ventilating, the patient is not breathing. That is why the carbon dioxide will accumulate within the blood. When carbon dioxide gets more within the blood, the more likely it is to react with water and form carbonic acid. When it forms carbonic acid, that leads to acidic state within our blood. And because this is because of respiratory failure, this acidosis will be called respiratory acidosis. Meanwhile, metabolic acidosis will also come in. So these are the phases through which the patient of acute respiratory distress syndrome ultimately goes towards respiratory failure. Alright, so now let's go on to the diagnosis section of acute respiratory distress syndrome. This is very important section, and you have to understand every single bit of this section. So first of all, how do we diagnose acute respiratory distress syndrome? There is a criteria for diagnosis of acute respiratory distress syndrome that is called Berlin's criteria. This is not the capital of Germany, but this is a criteria which we use to diagnose acute respiratory distress syndrome. Alright. So let's say, what does this criteria says? It says that the acute onset of respiratory distress should be there. Acute onset means less than 1 week. What does this mean? It means that the start of the symptoms of the distress, which were of course mild initially, to the state where the patient presents to the emergency department should not be more than 1 week. So start of the symptoms of the patient of the distress, right, to the state where the distress becomes so significant that we have to admit the patient in the emergency department, that time window should not be more than 1 week. That is the number 1 criteria. Second criteria is opacity. that when we do the chest x-ray studies, CXR mean chest x-ray, when we do the chest x-ray studies, we see ground glass appearance, right, which is equal to opacity, as we have discussed above in the phases section, right? So opacity, ground glass appearance on chest x-ray, we all know that these hyaline membrane that are now lining the inside of the alveoli and the protein rich fluid which is there, right, on chest x-ray, that will give, you know, white out area, white out or hazy pattern, so we call this pattern as ground glass appearance. This is the exact word which is used in your USMLE book, ground glass appearance, right? And that's one. Okay, now we have to differentially diagnose the acute respiratory distress syndrome from pulmonary edema. We all know that in pulmonary edema we also get the, you know, leakage of the fluid within the alveoli, right? And but that does not mean that we have you know, acute respiratory distress syndrome. So we have to differentially diagnose whether this is simply pulmonary edema or whether this infiltration is because of acute respiratory distress syndrome. Then how do we differentially diagnose it? How do we differentiate it? Here it's written that pulmonary edema on chest x-ray less than 24 hours after initial injury, initial insult to the lungs, that means that this is not ARDS. So if you had the contusion or any trauma or chest trauma to your chest yesterday, and today you have started to develop pulmonary edema, right? You see opacity on chest x-ray, you see ground glass appearance on chest x-ray, then that means this is not ARDS, this is simply pulmonary edema. So after initial insult or initial injury, whatever the cause of injury, if that opacity develops within 24 hours, right, that opacity on chest x-ray shows up within 24 hours, that means that is not ARDS, that is simply pulmonary edema, whatever the insult may be it contusion, okay, be it any sort of infection or whatever it is, right? That's one thing. Now other point for the Berlin's criteria is PaO2 over FiO2 ratio. It should be less than 300. We all know that PaO2 means partial pressure of oxygen within our arterial blood, and FiO2 means fractional inspired oxygen. So this ratio simply tells us how well our blood is getting oxygenated, how well is ventilation maintaining the oxygenation within our blood, right? If this ratio turns out to be less than 300, then we suspect that this is, yes, ARDS. Now the other criteria with which we can diagnose ARDS is PEEP and CPAP, right? If the PEEP or CPAP turns out to be greater than 5 centimeter of water, then it means that the patient is suffering from acute respiratory distress syndrome. All right, so this is quite tricky. Let me just explain what does this mean. So when the patient comes to you, you do not know initially that he is suffering from acute respiratory distress syndrome. You do not know. You just simply know that the patient is dyspneic, the patient is tachypneic. He has dyspnea and tachypnea, right? To give the initial first aid support, either you put the patient on positive and expiratory pressure through external mechanical ventilator, or you just simply give supplemental oxygen via CPAP. CPAP and PEEP is different because PEEP is something in which mechanical ventilator is involved. Via CPAP is something where we do not involve mechanical ventilator, we just have the supplemental oxygen going through the nose, right? So you have to give either of these two, either mechanical ventilation or CPAP. And after this, if you see these values, their values are greater than 5 centimeter of H2O, it means that the patient is responding well to this therapy. The patient is responding well to the mechanical ventilation that we are providing through PEEP. The patient is responding well to CPAP, means that yes, if the patient is responding well, then the patient was actually in need of it. When the patient was actually in need of it, yes, it means that the patient was in what? In respiratory distress. So that is how we confirm that yes, the patient came in respiratory distress, because after giving these two things, the patient responds well. And it simply means that the patient was in need of it and now he's responding well, so he is in respiratory distress syndrome. Okay, The next point is respiratory failure not explained by heart failure. When we know that in heart failure, when the heart is in a failed state, it cannot pump the blood out, right? It cannot pump the blood towards the external circulation. So what happens is that whatever blood is there, it starts to pool up. It starts to get accumulated within the heart. When it starts to get accumulated, it goes back into the lungs, right, through pulmonary vessels. When it goes back into the lungs, that causes pulmonary edema, right? So that happens in heart failure. So you have to understand that this respiratory failure or this opacity that we are seeing, that should not be because of heart failure, right? You have to know through history that this patient was heart patient or not. If this was heart patient means he was in a state of heart failure, and now he came with this distress, then you simply have to as a doctor assume that this respiratory distress is not because of the causes that we discussed in the pathophysiology section, but this respiratory distress is because of heart failure. So that's what you have to understand, and these are the diagnostic criteria for diagnosing acute respiratory distress syndrome. I hope you understand. All right, so let's just finish it out, the ARDS, with our treatment section. All right. So first of all, when the patient comes to you in the emergency department, you do not know that he is the patient of acute respiratory distress syndrome, but he is tachypnic and he is dyspneic. What should be your first aid strategy, right? Your first aid strategy should be to put him onto the mechanical ventilator. While you put him on the ventilator, you do not forget to maintain PEEP. PEEP is positive end expiratory pressure. The second point that I have written here, actually it should be the first point. That's the emergency treatment, emergency management, right? We have to put the patient on mechanical ventilation and we have to maintain PEEP. All right. And then we can identify the underlying cause. Like we have to know through the patient history, or after objective physical examination, we can know what is the underlying cause of acute respiratory distress syndrome. So if we come to know about the underlying cause, we can treat that cause. But that's the first aid that when patient comes in the emergency, that's the thing that we will have to do. All right. So what are the benefits of PEEP, right? What does PEEP do? PEEP helps to maintain pressure in the collapsed alveoli after every exhalation, right? We all know that when alveoli are in a state of collapse, right, it means no air is left behind after exhalation in the alveoli. That's when they are said to be in a state of collapse, right? So what does PEEP does? That PEEP after the end of every exhalation, while the patient is on the ventilator, after the end of every exhalation, that ventilator leaves some amount of pressure in the alveoli. Okay, because after next inhalation, it will not be hard for the inhalation to go in because there is already pressure in the alveoli. That's what the function of PEEP is. It maintains the pressure in the collapsed alveoli. Number two, it improves partial pressure of oxygen in the arterial blood. So these are the very important functions of PEEP, and we maintain PEEP by putting the patient on the mechanical ventilator, right? But remember, provide mechanical ventilation with low tidal volumes. That's very, very important, low tidal volumes, because we do not want to induce mechanical ventilation mediated injury to the lungs, right? That's why we are keeping low tidal volumes. That's one thing. Number two, keep FiO2. FiO2, you all know it's fractional inspired oxygen. Keep FiO2 less than 60% or 0.6. Why? If we do it more than 60% or more than 0.6, that may lead to oxygen toxicity. So we do not want any other complications. So you have to put you have to ventilate the patient in such a way that FiO2 should be less than 60%. And after doing all this, our goal is that partial pressure of oxygen should be more than 55 millimeter of mercury. That's our end goal. That's where we have to bring the patient, right? So when the partial pressure is achieved at 55 millimeter of mercury and saturation of oxygen in the blood is achieved at 88%, we say that the patient is in a stable state. So that's what we have to understand. So when do we extubate the patient? When do we extubate? Extubate means we have to stop mechanical ventilation. When do we have to stop the mechanical ventilation? Here it's written that if you have treated the underlying cause and also if the patient has passed the spontaneous breathing trial, right? So you can just check that whether the patient can breathe without the ventilator or not. If the patient is responding well, right, and he can breathe for significant amount of time without the mechanical ventilator, then you can consider stopping the mechanical ventilation, right? Then it means that the condition of the patient has been improved. So that's when you can extubate the patient. So that was with the treatment section, and with this we are finished with the part 2 of acute respiratory failure, that was acute respiratory distress syndrome. I hope you liked the video. If you guys like the video, please share the video, subscribe the channel, and don't forget to comment.